Good afternoon. I'm Dr. Antonios Sfakianakis. I'm fertility clinical fellow at Homerton University Hospital. And I would like to welcome you all to our webinar today, and specifically to our session. And first of all, I would like to thank Endometriosis UK for inviting me here today. And for the next 20 minutes, we will be discussing about a very interesting topic, which is endometriosis and infertility. Now, first things first, let's begin with the definitions. Now, endometriosis is the presence of endometrium outside the womb, and it includes an inflammation process. Whereas couples with infertility are the ones that have been trying actively to conceive and have not managed after having regular sexual intercourse. According to the National Institute for Health and Care Excellence, the NICE, a couple should be referred to a fertility specialist after 1 year of trying actively, if they don't have any identifiable cause of infertility. You can also see here the endometriosis staging system by the American Fertility Society based on the findings during surgery. And as you can see, stage 1 and 2 are minimal and mild cases, whereas stage 3 and 4 are moderate and severe cases. Unfortunately, no staging system correlates well with the chance of conception following therapy. And you should keep this in mind later when we will discuss the relationship between stages and fertility management. But what about epidemiology? As you can see here, there is an association between infertility and endometriosis. Classical studies suggest that 25% to almost half of infertile women have endometriosis, and 30% to almost half of women with endometriosis are infertile. The causal relationship between endometriosis and infertility has not yet been clearly established. But what are the biological mechanisms that can explain this relationship? Well, it depends on the stage of endometriosis. Now, in severe cases with adhesions, when we say adhesions, we mean the scar tissue similar to cobwebs inside abdomen. The egg release can be affected, or even the capture of the egg can be affected. Fallopian tubes might be obstructed also. And there are other theories suggesting that the peritoneal fluid might contain inflammation mediators that can affect egg fertilization. Now, when it comes to fertility, we need to take into account the lining of the womb also. Evidence suggests that endometriosis can affect the interaction between the embryo and the endometrium, and that increased antibody levels might play an important role in that. What about egg and embryo quality? It has been shown that egg quality can be affected by endometriosis, and this was supported by a study that looked at women without endometriosis who received donor eggs from women with endometriosis, and they concluded that success rates were lower. Obviously, we need more well-designed studies in order to be able to come to a safe conclusion. In the second part of the talk, we will discuss about the management of women with endometriosis, and I will present to you the main guidelines that are widely followed. And these are the European Society of Human Reproduction and Embryology guideline, the NICE guideline, the American Society of Reproductive Medicine guideline, and the Human Fertilization and Embryology Authority guidance, and the HFEA guidance. And HFEA is the regulatory body for all fertility treatments in England. Let's start with hormonal therapies. Is there a place for them in managing endometriosis? In fertility and endometriosis? With the term hormonal treatments, we mean the combined oral contraceptive, the coil, the intrauterine coil, the progesterone pill, the progesterone implant, or even the injection, and the GnRH analogs. They are mainly used to improve endometriosis-related pain. Fertility is essentially eliminated during treatment because they inhibit ovulation and they can act as contraceptives. Basically, they only delay treatment, and ESHRE advises that they don't improve fertility. The aim of the medical treatment is to shrink the hormone-dependent endometriotic tissues, and most of them prevent pregnancy, but contraception is advised throughout treatment because these drugs can harm the unborn baby, and the contraceptive effect of the treatment should not be relied on. What about surgical treatment in women with minimal and mild endometriosis? Both NICE and ESHRE agree that laparoscopy and adhesiolysis, when we say adhesiolysis, we mean the removal of scar tissue in the abdomen, contribute to increased pregnancy rate. This has also been proven by this systematic review that reported that surgical treatment of minimal to mild endometriosis increase the chances of getting pregnant naturally, as you can see here, compared to diagnostic laparoscopy, as you can see. Now, I'm just going to explain to you this forest plot. If the diamond that you can see here touches the vertical line, the overall result is not statistically significant. Now, the results to the right of the vertical line favor the treatment over the control. And if the diamond is not touching the vertical line, like in this case, the overall result is statistically significant. So in this case, the difference is statistically significant. Now, what about surgery in more severe cases? Evidence, again, suggests that in these cases also, surgery can improve the chances of getting pregnant naturally. But who is more likely to benefit from surgery? The Endometriosis Fertility Index is a clinical tool that is used to identify who has higher chances of getting pregnant. It is a combination of different parameters. During surgery, we assess the fallopian tubes, we assess the ovaries, and we also take into account patient's age, the previous pregnancies, if there are any previous pregnancies, and the years of infertility. And also we take into account the American Fertility Society endometriosis score, as we described it earlier. And you can see in this graph here that women with a high score, here, the blue line, can have up to 80% pregnancy rate after 3 years. What about the management of endometriomas? Endometrioma is a fluid-filled cyst that can be referred as chocolate cyst. When fertility is a priority, removal, we would say, is preferable to drainage. But when we design treatment, we also need to take into account the higher risk of removing healthy ovarian tissue inadvertently. As you can see in this systematic review, excision is recommended over ablation, and as it increases spontaneous conception rate, you can see here the diamond. Now I'm going to introduce to you the two main treatments that we use in reproductive medicine, which is intrauterine insemination and IVF. Now, in intrauterine insemination, also known as artificial insemination, we stimulate the ovaries with injections, and we monitor the cycle with serial scans. And when a big follicle of about 18 millimeters is developed, we trigger the ovulation with another injection. And next day, we take the partner sperm, we wash it out, we take the best of it, and then we inject it inside the womb. Essentially, it's a concentrated sample. The main prerequisite for this treatment is tubal patency, so the tubes need to be patent, and normal semen, normal sperm. Now, in IVF, we stimulate patients' ovaries with higher hormonal doses, and we monitor the cycle with serial scans. And when patient develops follicles of about more than 18 millimeters, again, we trigger with an injection, we trigger ovulation, and we collect eggs 36 hours later. Egg collection involves the aspiration of fluid out of the follicles with a fine needle under ultrasound guidance. You also collect partner sperm, as you can see here. We mix sperm with eggs, and we create the embryos. We culture these embryos up to day 5 or 6 of embryo development, what we call a blastocyst stage. And then we transfer one embryo or two into the womb with a thin catheter, a procedure that is called embryo transfer. Now, intrauterine insemination is less expensive and less invasive, but has lower success rates. Success rates are about 10% and is not recommended in severe endometriosis. But in mild and minimal cases, ESRE, the European Society, again recommends IUI instead of expectant management, as it increases pregnancy rates. Now, what about IVF and endometriosis? From studies, we know that endometriosis might affect IVF results, but at the same time, IVF is more likely to improve fertility, especially in the group of women where severe endometriosis, like where fallopian tubes might be affected. Then in these groups, we would say the benefit is higher. Now, what about GnRH analogs prior to IVF treatment? GnRH analogs suppress estrogen production in the body, and evidence suggests that it can improve success rates if given prior to an IVF cycle. This was supported by a large systematic review of literature, as you can see here on this slide. Now, this systematic review has looked at the effect of endometriosis on IVF results. As you can see here, the clinical pregnancy rates were lower in women with endometriosis, but when live birth rate was compared, as you can see here, as an outcome, no statistically significant difference was found between the two groups. Now, is there a place for surgical treatment in women with endometriomas prior to IVF? Well, answer is not simple, I would say. Now, this systematic review looked at this question. And as you can see here, there's no statistically significant difference in terms of success rates between the group of women who had surgery for endometrioma and those who had not. You can see that all the diamonds are crossing the line. On this slide, you can see the possible benefits and risks that we need to take into account when we decide on surgery in patients with endometriomas. Now, possible benefits of surgical treatment prior to IVF, especially for large endometriomas, include easier access to ovaries during egg retrieval. And as you can see here, with a needle transvaginally, we aspirate the eggs out of the ovaries here, and the endometrioma might obstruct the access. On the other hand, disadvantages of surgery include, as you can see here, inadvertently removing healthy ovarian tissue, and of course, possible surgical risks. Now, in order to summarize, as you can see on the slide, when we design treatment for endometriosis-related infertility, we need to take into account all these parameters in order to achieve the best outcome. You can see that female age, we will talk about it later, is a very important factor. Now, what are the take-home messages then? So endometriosis can affect reproductive potential, definitely. In younger women, we would recommend expectant management or intrauterine insemination. But in older women, intrauterine insemination or even IVF would be recommended. Also, I would like to highlight here the role of the multidisciplinary team and the role of the personalized and tailored treatment. Their role is of paramount importance, and especially in complex cases. So, is there a hope for women with endometriosis fertility? The answer is absolutely yes. Both surgery and assisted reproduction technologies can improve success rates in women with endometriosis-related infertility. Moreover, as you can see here, surgery is recommended by all the societies in both mild and severe cases, and it can be beneficial and improve pregnancy rates. Now, on this slide, you can see an algorithm for the management of endometriosis-related infertility. Now, first of all, before we start treatment, we need to assess ovarian reserve. And how we do that? Most of the times we do that with a hormone that is called anti-Müllerian hormone, AMH, and it's a hormone that is indicative of the reproductive potential and of the response of the patient to the treatment. Now, in younger women with good ovarian reserve and mild endometriosis, we would recommend expectant management or intrauterine insemination. Now, in moderate cases, if the pelvic anatomy and the tubes are found to be patent during laparoscopy, this is this arrow, we would recommend IUI. But if the pelvic anatomy is affected and fallopian tubes are blocked during laparoscopy or affected, we would go down this route. So we would recommend IVF. Now, also in older women with poor ovarian reserve, we would advise, again, as you can see here, to go straight for an IVF treatment. Here you can find an overview of the management of endometriosis advised by the NICE. And as you can see, this is the most interesting. As you can see, in severe cases, we need, as we've said before, we need to take into account possible impact to ovarian reserve and complications of surgery. You can find more information about fertility treatments and fertility in general in the HFEA website. You can also visit Fertility Network and Endometriosis UK, and you can also contact us at Homerton Fertility Center. Thank you very much for your attention. Now I would like to ask to answer one of the questions. One of the questions was, can Prostap affect your fertility and bone density in the long term? And what is your viewpoint in terms of fertility? Now, Prostap is leuprorelin acetate and belongs to the GnRH analogs. We can use it either to suppress endometriosis prior to surgery or to prevent recurrence and to improve endometriosis-related pain. Now, both spine and hip bone mineral density decrease after 6 months of GnRH analogs. So it is advisable to offer add-back therapy in order to supply enough estrogen to the body. For adback therapy, we would normally use a drug named Tibolon, hormone replacement therapy, or even the combined oral contraceptive pill. As I mentioned earlier at the presentation, GnRH can be used in fertility treatment prior to IVF to increase success rates in women with endometriosis. We also use them to suppress ovulation during ovarian stimulation. Nevertheless, we only use them for up to 3 months. So bone mineral density, we would say, is not significantly affected. As for the second part of the question, at the moment, there is no evidence of long-term effects of GnRH analogs on fertility. And with this answer, I would like to finish my presentation. Thank you very much for attending today. And thank you very much. I would like to thank Endometriosis UK again for inviting me to give this very interesting talk. Thank you very much.